Hello, everybody. Welcome to the United Leukodystrophy Foundation's virtual family conference session on 4-H, presented by Dr. Bernard and Dr. Wolf. This session is being recorded and will be posted for viewing online in early July. Thank you so much for joining us. And now I will turn it over to Dr. Bernard. Thank you.
And I think yesterday I had some technical problems. So I think today is going to be better. Okay. You hear me well?
Yes, I do.
Yes. Okay, good. So I think most people know me. I'm Dr. Bernard. I'm a pediatric neurologist and a clinician scientist at the McGill University Health Center Research Institute. And my research focuses on polar 3 related leukodystrophy, or 4-H leukodystrophy, and talking with the Yaya Foundation for 4-H leukodystrophy. One of the questions that came an interest for a presentation was to talk about supportive care for patients with 4-H. So that's what I'm going to talk about today. Sorry, so I do not have any significant disclosure for this talk. However, I'm involved in several foundations. I'm an investigator on pharma and biotech company trials, and have been funded by different agencies through the year for my research. So before we start, it's very important to realize that the information I will present is not meant to be used for a specific patient. I will talk about generalities to manage patients with 4-H, but you can't apply directly to your child. Every child is different, and you really need to discuss the management with your treating physicians and your treating team. So if you some references for your physician, I guess, is this article that we published in 2017 about supportive care for patients with leukodystrophies. There is a section specific for 4-H, but also a lot of information regarding things that are difficulties that are shared by more than one leukodystrophies. And the family version of it, which is written in lay language, is available online. So if you want to have a look at it. So the work we do on 4-H could not be done without international collaboration. So I want to acknowledge that I'm very grateful for the collaborations we have. The main collaborator on 4-H for clinical research is Nicole Wolf, which is going to present right after me. So 4-H is an autosomal recessive disease, which means that both parents carry a gene that's not working well. And then if you do the math, there is a 25% chance of having an affected child with every pregnancy. There's a 25% chance of having a child that is not a carrier. And then there's a 25% chance, a 50% chance of having a child that is a carrier, like mom and dad, and will not be sick. It is caused by mutation in 4 genes. Polar 3A, Polar 3B, and Polar 1C account for the vast majority of cases. And there's a handful of cases caused by mutations in Polar 3K. In 2014 and 2019, together with the group in Amsterdam, led by Dr. Wolf, we've looked at a series of patients with either Polar 3 and Polar 3B in 2014 and in Polar 1C in 2019 to better understand the clinical manifestations of the disease. So this is a schematic that's going to come back several times through the talk. So there is hypomyelination, hypodontia, so teeth abnormalities, and hypogonadotrophic hypogonadism or other endocrine abnormalities. And there's also myopia, which is not part of the 4-H, but is also a significant clinical feature. So we're going to go through some of the difficulties the patients have and how these can be managed on a day-to-day life. So the first thing I want to talk about is the cerebellar feature. So the ataxia, the difficulty with balance, dysmetria, which is imprecision when doing small fine motor tasks, dysarthria, so slurred speech, and tremor, which is often cerebellar in nature for patients with 4H. Cerebellar features, so I mentioned them already. So the way we manage these is it is important to avoid falling. So for the patients that are still ambulatory, because if they fall and have a fracture of their of the leg bones, for example, and they have to be immobilized for like 6 weeks, for example, then it will be hard for them to recuperate and be able to walk again. Because if you take a normal typical child, a child that is normal neurologically, and has a leg fracture, for example, it will take them time to recuperate after the immobilization. So for our kids with more problem with motor skills, it is something that that is more significant. And then regarding the cerebellar tremor, which most patients have, we see that, in my experience, we see this more with the patients with POLR3A mutation. It does not respond well to medication. For some patients with 4H, for every patient, it's very important to be assessed by a neurologist for the tremor, because there are a minority of patients for which the tremor is a dystonic tremor, and that responds well to medication. So it is important to have a very thorough assessment. And for the slurred speech, as the disease progresses, it may be difficult for the child to express themselves and being understood. So it is important that a speech and language pathologist be involved for assistive communication devices, pictogram, etc. So the pyramidal features, we call it like this because this is a scientific word for stiffness, so increased tone. And you see other things on examination. When your neurologist examine your child, you see that when they do the hammer, the reflexes, they're brisk, they're strong. And then when the doctor scratch in the bottom of the foot, you see the big toe goes up. And so some of our kids with 4H also have clonus. So when you flex the foot quickly, there's a tremor of the foot that appears. And then when you reposition the leg, then it stops. So management of stiffness, of spasticity, is stretching, occupational therapy and physiotherapy. And also there are some equipment that can be used to improve function. So for example, an independence. So orthosis sometimes can be helpful, a walker, a wheelchair, to favor independence for the children that have difficulty walking. But in general, for the 4H patients, the spasticity is not such a big problem. And so it's rare that we have to give medication for it, but there are medications for spasticity. The most common one is called baclofen. The only thing you need to think about when you treat a patient for spasticity is, for anything, you have to make sure that the actual symptoms that you treat is bothersome to the patient, because every medication has potential side effects. And so you need to make sure that what you treat is something that will be meaningful for the patient. And so the baclofen is something you take by mouth most of the time. And it loosens the muscles, but not only the muscles that are stiff, it loosens everything. So for our kids that have difficulty holding their head, if we give them baclofen, it makes it more difficult for them to hold their head. So you have to be careful about prescribing this. You really have to make sure that the spasticity bothers the child. If there are specific muscles that are problematic, botulinum toxin injection can be done. One example is when diaper changes are difficult because of increased tone. The doctors may inject a adductor, so the leg muscles, some leg muscles in the thighs, to make sure to facilitate hygiene and diaper changes. There are orthopedic surgeries that can be done for pyramidal features, as well as neurosurgical interventions such as baclofen pump, or selective dorsal rhizotomy. I've never had any patients with 4H who needed who needed significant treatment for their spasticity. It's usually not such a big problem. So extrapyramidal features. So the most common one is dystonia. So dystonia is a contraction of muscles. Often the muscles that do both, we say agonist and antagonist muscles. So the same muscle that makes them, so when you extend your wrist like this, some muscles are working. If you bend your wrist, some muscles are working. But if the two are working together, then you get a posture. You often get abnormal movements as well. They're typically twisting movements, and they can also be tremulous. So for the dystonia, stretching is important to avoid contracture. A lot of patients have what we call a sensory trick. So for example, if they have a posture of the hand like this, a lot of the, like, if you put your finger in the middle of the hand here and you press off, for some of the kids, it just makes them much looser. So you have to look into this with your child. Sensory trick is a characteristic that we see often with dystonia of different kind. One other example is patients that have like a posture of the head and a tremor of the head. If they put their hand like this, most of the time it's going to stop. There are drugs that should be avoided in patients with dystonia. There are the drugs that block the D2 blockers and the D2 receptors in the brain. So such as metoclopramide, which is a medication to improve to fasten digestion, and neuroleptics, and there are others. So these should be avoided because it can cause more dystonia. For the kids that tend to fist, it's important to keep the nails short because they can hurt their palm, and if they do, then because they're always fisting, it doesn't heal. It's very hard to heal. So cutting the fingernails short is very useful for this. And there are medications for dystonia. The most commonly used medication is triexiphenidil or Artane. It is a very old medication. It works really well for dystonia, but it does have side effects. So when we start treating it, we need to make sure that the patient is actually bothered by it. If there are specific muscles that are problematic, botulinum toxin injection can be used, and there are surgical options for dystonia, such as baclofen pump and DBS. I've put them in parentheses because these are they're typically not used by patients with 4H. We looked at a few years ago, we looked at a series of patients with 4H, and a lot of patients have dystonia, but the vast majority of them are not bothered by it. It's very mild. It doesn't impair their daily life, and they do not require treatment. The cognitive impairment. So it is important for our kids to be assessed regularly by a neuropsychologist or a psychologist to adjust our expectations regarding their learning and also to orient their education. It's also important for them to have an individual education plan at school, which will take into account their cognitive difficulties, their motor difficulties, and for some of them, their visual impairment. So that we foster, we make sure that we encourage them to succeed as much as they can, but we don't push them too hard, and we preserve their self-esteem. So myopia is not part of the 4H in the name, but it's it's almost universal. Almost all patients are myopic, and so they need glasses. But the myopia typically progresses over time. So it is very important for all kids with 4H to be seen by an ophthalmologist. We typically recommend every 6 months until it's been stable for a long time, and then you can probably go every year. But it is very important because then you adjust the glasses as the myopia progresses, and it does help them do on a daily basis to be able to do their. It's important to see when you want to go to school or do your things at home. The dental abnormalities. There are different types of dental abnormalities. You can have delayed eruptions of the teeth, abnormal pattern of the eruption of the teeth, some teeth that are missing, teeth that are smaller, teeth that have abnormal shapes, etc. So it is important for every kid, but even more for patients with 4H, to be seen regularly by a dentist and an orthodontist if needed. Endocrine abnormalities. So just very recently, we published a series of 150 patients and looked at the endocrine abnormalities. And then, not surprisingly, the most common one is the hypogonadotrophic hypogonadism, which is either delayed, arrested, or absent puberty. The decision to whether to treat the abnormal puberty should be individualized. Short stature was seen as about 50% of patients. Only a minority of them, though, were tested for growth hormone deficiency. Some of them did, but we couldn't conclude for a general statement about why if all patients with short stature, or like a majority of patients with short stature had it because of growth hormone deficiency. We weren't able to do this because most patients were not. The vast majority of them were not tested for it. We had patients with hypothyroidism as well. It was more common in our 4H patient population than in the general population. So what we've learned from this is that we need to investigate the patients with 4H earlier than we used to. We used to investigate them around puberty. I think they should be seen earlier and followed regularly by an endocrinologist or by their family physician or their pediatrician with regular blood tests to assess their hormone and a questionnaire regarding potential symptoms of hypothyroidism or other hormone abnormalities. So the treatment for hypogonadotrophic hypogonadism, as I said, it has to be individualized. We weren't able to make a formal recommendation. We need more data for this to make recommendations. The potential benefits versus risks of treatment need to be weighted to make the decision. So the potential benefits are the promotion of bone health, which is important for our kids. Normal puberty, development of secondary sexual characteristic is important, especially in our very high functioning children. And then the risk, a rapid growth spurt could enhance the motor difficulties and can cause behavioral problems. And there's also potential side effects of the treatment. So before decision can be made, the risk and benefits need to be weighted. And then you need to have the proper sex hormone levels. And then you have to consider the overall health of the patients, whether or not they're well. We have some patients that are very mild, and then when they're teenagers, they're still walking and very functional. But we also have, unfortunately, kids that are much sicker, which when they're adolescent, they're wheelchair bound, and they're getting very sick. And these patients, we may decide not to treat according to the overall clinical picture. So there are other clinical manifestations that are common to other leukodystrophies that are also important to consider in patients with 4H. So the dysphagia, which is a difficulty swallowing, can lead to coughing, choking, or when drinking or feeding. It can also present as unexplained weight loss, or the change in the type of food that the child is eating. If they prefer softer food, also change in the voice, especially after meals, regurgitation through the nose, drooling, recurrent pneumonias. So we want to manage this in a multidisciplinary fashion with a neurologist, an ENT doctor, a nutritionist, primary care doctors, OT, PT, OT, and speech language pathologists. They need to be, the evaluation needs to be done regularly because the dysphagia, unfortunately, in most patients progress over time. And if we address it early on and make the changes in the feeding, the way we feed the child, we avoid a lot of complications. We avoid the chronic lung disease. We avoid a lot of the aspiration pneumonias as well. So an OT or a speech language pathologist, depending on where you are, can do a swallowing assessment. A video fluoroscopy can also be done. Some ENT doctors do functional endoscopic evaluation of swallowing. So usually the easiest, at least in our center, is to do regular video fluoroscopy. And then we do it according to if the patient is stable, we do them less often. If the patient is not doing so well, we do them more often. And on average, I would say we do them approximately every 6 months. And then the main treatment is changing the way we feed the child. So the first thing we do is avoid mixed textures. With the, like, for example, the soup with the very tiny hard veggies in it. This is very difficult to manage when you have trouble managing food in your mouth and in your throat. So that's the first thing we usually stop. And then the second thing is thickening the fluids. And there's thickeners that are available for that. Cutting the food in very small pieces, giving some soft food, adding sauce to the meals. And there are other things that can be done. In general, not giving, so feeding the kids with 4-H like you would feed the child less than, like when they start having dysphagia, you should consider making all the same habit that you used to do when they were younger than 3 years old. So cutting the sausage like in a long I'm sure you know what I mean. I'm sorry. I can't explain it in English. And then not giving like the candies, making sure that they're not round, and like all you would do with a younger kid when they have dysphagia is important to make sure that you do all these precautions. And then when the dysphagia becomes severe enough, some kids need to be fed through a tube, either an NG tube or a gastrostomy or a gastrojejunostomy. Drooling. Drooling is abnormal after the age of 2. It has several causes. It can be because of abnormal oral control. It could be because of abnormal swallowing, malocclusion or structural oral problems, mouth breathing, postural problems, so the ability to hold their head up, for example, their axial tone, and it can be also due to medication. In our kids with 4-H, I guess all of them except perhaps the last one are things that contribute to their drooling. It has an impact on the patient, so it's not like it's uncomfortable for them. They can have skin infection, dehydration, they can have pneumonias, and it's also an hygiene issue. There's also, for the kids that are higher functioning, stigmatization, rejection from the other kids, isolation, and poor self-esteem. And there's also impacts on the parents regarding the burden of care, the wiping, changing their clothes, cleaning, the hospitalizations, anxiety, social isolation. So it is not a trivial problem. So if it bothers the child and or the parents, then it should be treated. Otherwise, it's okay not to treat. It should be a multidisciplinary approach when we decide to treat. There are rehabilitation techniques that can be taught to the child if they're able to learn them. And there are some medication you can give as well. In our experience at the children in Montreal, the botulinum toxin injection works really, really well, and we like to give this to our patients. And there's also surgical options. Epilepsy in patients with 4-H is relatively rare. It's when there's epilepsy, it's relatively easy to control. So it's to diagnose the epilepsy, you need to do a good history, see if you can see the event, it's good, and the EEG is also helpful. The way we decide to treat the seizures is the epilepsy is according to the type of seizure the patient has. And there are also the side effect profile of the medication that we could decide, that could help us decide which medication to use. For example, clonazepam tends to increase and thicken the secretion. So for the patients that have dysphagia, it may not be the best option. It may be too, but it may not. So it's something that you can keep in mind. And then the need for regular blood tests or not. So if the epilepsy starts later in the course of the disease and the patients are very sick, I usually tend to take medication that they won't need a blood test to try to improve their comfort. Positioning is important for prevention of orthopedic complication. So a regular visit to a physiatrist or a rehab physician is important to look at the hips. So clinically and with x-rays to prevent subluxation and dislocation, to help prevent pain, and hygiene, to make it hygiene easier. Positioning and treatment of spasticity and dystonia is important for the hip, and referral to an orthopedic physician as needed. Regarding the spine, again, it's a clinical and x-ray assessment. And to prevent or treat scoliosis or kyphosis, in order to prevent pulmonary complications and to prevent pain. So for the spine, as you may know, positioning is important, and wearing a corset can help as well. And again, a referral to an orthopedic physician can also be done. There are multiple other things we could have discussed today regarding rehab, other types of movement disorder, prevention of falls in more detail, fatigue, bone health, skin care, psychological health of the parents, patients, or siblings, etc. But there was not enough time to talk about everything. I just wanted to introduce our teams of doctors that some of you know because you came to Montreal at our conferences. So Marie-Emmanuelle Dilange, who's a pediatric neurologist and expert in spasticity treatment. Elisabeth Simard-Tremblay, also a pediatric neurologist and expert in epilepsy. Sam Daniel, our ENT doctor. Sylvain Chouinard, who is an adult neurologist and expert in movement disorder and trained me during my fellowship in movement disorder. And Gaëtan Filion, our physiatrist or rehab doctor. The other thing I was asked, so these are the funding we had over the years to work on 4-H. I was asked to present a little bit what we did in terms of research in the lab by the Yaya Foundation. So I wanted to thank patients and family for participating into our research. So we have an adult neurology team, Dr. Bray, Dr. Lapiana, Tom Durkin, who is helping us with the iPSC work, Tim Kennedy, who's helping us with all of our myelination assay, Benoit Coulombe, who's working on all the proteomic work we do, David Rudko, who's doing the MRI on our mice, and Alan Evans, who has helped us build our myelin neurogene rare disease databases. And then the international collaborators, I wanted to highlight Nicole Wolf, with whom we collaborate closely for all the clinical work, and Adeline van der Veer, with whom we also work very closely for the 4-H. We recently started working with Paul Tissar for the iPSC work that we do, and with Grant Pingao for the development and gene therapy for 4-H. These are my graduate students, Stéphanie Perrier, who works on an iPSC model of the disease, Michel Robinson, who's working on the mouse model, Julia McIntosh, she works on mouse oligodendrocytes work for 4-H, Hiria Tontucci, who is working on the natural history, on the retrospective natural history of 4-H, and Alexandra Chapio, who is working on another hypomyelinating leukodystrophy. She's working on an iPSC model. My clinical research assistant, Luan Tran and Simon Fournier, and Alexa Dirksen, who works on our next generation sequencing projects, Xaru Chen, who's working on our mouse projects, and Lama Derveli, who is also working on our mouse model. And then we have some summer students, and I just realized I'm missing one picture, who are working on next-gen sequencing, on natural history studies, on developmental milestone in patients with 4H, etc. Thank you.
So thank you so much. My name is Nicole Wolf. I'm a child neurologist from the Amsterdam Leukodystrophy Center. And I thought quite a long time what to talk about today. I wanted to share a little bit of our experience with other leukodystrophies, how to design, hopefully, in the future, also for 4H clinical trials. There are no disclosures for 4H leukodystrophy, and I'm grateful to different funding agencies. As I said, I'm working in the Amsterdam Leukodystrophy Center, and headed by Mario van der Knaap. We actually worked and still work a lot on MRI analysis, including quantitative MRI parameters. We defined several new leukodystrophies, and the causal genes are doing natural history studies, have a very active neuropathology lab for the brain donations we receive from children and adults with leukodystrophies. And that helps a lot to understand disease mechanisms. And recently we started also to set up treatment trials for leukodystrophies. And that's a very exciting time. That's part of the Amsterdam Leukodystrophy Center team, and you see a lot of enthusiastic young people, which is great, because we all hope they will continue in the leukodystrophy field. So as Geneviève already pointed out, 4H leukodystrophy, as many other leukodystrophies, is an ultra-rare disease, so collaboration is the key, and it needs to be international collaboration. I just wanted to recap how white matter is built, because I think that's helpful also later on when we talk about gene therapy or hematopoietic cell transplantation. So we have, of course, blood vessels bringing in all kinds of nutrients. We have the neurons with the axons, the long nerve fibers, which convey the information. We have the oligodendrocytes producing the myelin sheath, which are wrapped around the axons. We have the astrocytes, which are a little bit of the caretaker of the brain. They remove debris and help to provide a stable environment for all those cells, and also help oligodendrocytes to build up the myelin. And we have microglia, which are kind of a brain, own brain immune system. And those are the main components of the white matter. And also important for 4H is to have a little bit of knowledge about normal myelination, because that's what is not working well in many patients with 4H. Usually the brain white matter is myelinated in the first 2 years of life. And you see how the MRI changes over that time. And the white matter goes from white to almost black in this method of brain MRI. And this signal change is due to the oligodendrocytes who make those myelin sheaths, which are wrapped around the axons. And that's a very, very tightly regulated process, which needs all cells in the brain and also nutrients from outside the brain, as thyroid hormones, iron, glucose, and so on. And we can follow that very nicely on the MRI. And you see that we can also really demonstrate different amounts of myelin during normal development. So 4H is a hypomyelinating disorder, which means a significant permanent deficit in myelin deposited, and one of the H's in 4H comes from hypomyelination. And it looks very much like the MRI of a neonate compared with the MRI of a healthy child. And there are many different hypomyelinating disorders. 4H and Pelletier-Merzbacher disease are the most frequent ones, but you also see that there are a lot of very, very rare and new disorders. And in collaboration with several researchers, also with Dr. Bernard, we managed to identify several of those hypomyelinating leukodystrophies. So the MRI of 4H syndrome shows hypomyelination, but in addition also cerebellar atrophy, which means that the cerebellum structure in the back of the head is smaller than usual. This MRI doesn't necessarily predict how severely affected a child is. With the MRI like that, a child can be wheelchair bound, but can also walk around with almost no symptoms. And why that is the case, we haven't understood yet. I think I skipped that. The clinical evolution of hypomyelination is for 4H syndrome, but also for the other hypomyelinating disorders, often that we have a long stable phase, but in the second or third decade, sometimes later, sometimes earlier, also depending on the disease, we see, unfortunately, a decline and also some atrophy, some tissue loss in the brain. And we think that this comes from the not so well protected axons in hypomyelination, where we have only a little bit of no myelin, which over time means axonal damage and neuroaxonal loss in the brain. So the challenge for 4H or polar-3 related disorders is that this is, and that's something we've learned only in the last couple of years. It's different disorders. We have the typical form with hypomyelination and the myelin deficit. We have a very similar disease. I couldn't tell from seeing a patient, but there are patients who have almost normal myelination. We have forms with more or less normal myelin, but prominent spasticity, and a form with a basal ganglia involvement and a lot of dystonia, as Dr. Bernard already pointed out. We also have different speed of disease evolution, early onset and severe symptoms, and late onset patients, sometimes as late as in adulthood with very mild symptoms. And we are still puzzled by how that comes. So we haven't understood that well. There are other leukodystrophies with different ages of onsets, and I would like to show you some examples of metachromatic leukodystrophy to illustrate that point. You have in this leukodystrophy, which is relatively frequent and has been known for a long time, so we have more information also on natural disease cause. We have 4 presentations which are very well defined according to age of presentation. So it can range from children in the first or second year of life until adults even after the age of 50 years. And you see that disease progress, the speed of disease progress, like losing walking without support, is very different in the younger patients compared to the older patients. And this is also true for the more severe motor involvement. And you can imagine that if you think of an intervention trial where you do a treatment, that it will be very challenging to prove effects of a treatment when you do that in patients with a slow disease progression, because you need a lot of patients and a very long trial time to show effects of your treatment. And that's even more the case for patients with MLD who don't have many motor symptoms or almost no motor symptoms, but purely a dementia. We call that cognitive onset, and their disease progression regarding loss of motor function is even much slower, and many patients don't lose motor function even 20 years after disease onset. So what kind of treatments do exist already for leukodystrophies? You probably have heard about some of them, and I wanted to tell you a little bit more of them, because it's quite, I think, interesting to know what's going on for other leukodystrophies and whether that may be an option for 4H. We have the hematopoietic stem cell transplantation, which is used for metachromatic leukodystrophy, X-linked adrenoleukodystrophy, selected cases of Krabbe disease, and for adult onset leukodystrophy with axonal spheroid pigmented glia, long name. What happens, you treat a patient with a leukodystrophy with a very high dose and severe chemotherapy. We call that myeloablative chemotherapy. And that chemotherapy eradicates your own bone marrow. So you do need a graft, a transplantation from a donor, a healthy donor. And his hematopoietic stem cells, which come from the bone marrow, cord blood or peripheral blood, actually migrate into the bone marrow and make normal blood cells like red blood cells, white blood cells, platelets. And a subset of the white blood cells actually migrates to the brain and produces the enzyme which is missing in patients with metachromatic leukodystrophy. And in the brain, they replace the microglia, the brain immune cells, but not myelinating cells, oligodendrocytes or neurons. There is also gene therapy, and for metachromatic leukodystrophy, it is all the studies are finished, and the gene therapy is about to be registered in the EU. And the principle is very much similar to the bone marrow transplantation with the donor cells. You also give a myeloablative chemotherapy to eradicate the patient's bone marrow. But instead of giving, oh, I think I put in the wrong illustration, I'm sorry about that. Instead of giving the donor stem cells, you give patients' own stem cells, which have been corrected genetically. And again, those cells make macrophages and go to the brain to replace the diseased microglia and to produce the enzyme. And also this treatment doesn't replace myelinating cells or neurons. And the results are very nice. This is an untreated patient at the age of 40 months, and that is his sibling. And at the same age, you see an almost normal MRI scan. And when you look at motor function, for example, you see that many treated children have a normal motor function and also a normal cognitive function. And also when you look at the MRI looks not completely normal, but quite well in the treated children compared to the untreated children you see in gray. So the treatment works when you give it early enough. When the damage is too large in metachromatic leukodystrophy, it doesn't work anymore. And how do we think those treatments work in the brain? we have those healthy, functioning patient macrophages or donor macrophages, which migrate into the brain and produce the enzyme which is missing in metachromatic leukodystrophy, and can actually remove all kind of stored material, which then actually leaves the possibility for oligodendrocytes to proliferate, to develop, to differentiate, and to make normal myelin. So that's what we think, how it works. And this is a normal brain white matter images of a patient treated with hematopoietic cell transplantation, and a very nice treatment success for the brain. Other treatments tried in the past or in current trials for leukodystrophies are enzyme replacement therapy, which we use for metachromatic leukodystrophy, where we actually replace the missing enzyme directly into the brain via a small portacat. We have a smart molecule treatment or drug repurposing, and we just started in Amsterdam a trial with guanabans for vanishing white matter, and we are preparing a trial for Pelletier-Merzbacher disease. And there has been a trial for metachromatic leukodystrophy, where gene therapy was directly administered into the brain with injections in different brain parts. This has worked very well in an ape model for metachromatic leukodystrophy, but completely failed in the 4 patients in whom it had been administered. And why isn't known yet, unfortunately. So the challenges for all trials are how to select patients for a trial to best prove efficacy. Because of course we want at the end of a trial know whether treatment works or not. And that sounds like a very trivial question, but it's actually a difficult question. How long to do a trial to be sure something works or doesn't work? How to decide an intervention is successful, so what is the outcome we are interested in? And how to choose objective markers, we call that biomarkers, next to clinical markers like motor function. Treatment approaches, possible treatment approaches for hypomyelinating leukodystrophies have been thought of already for a long time. Hematopoietic stem cell transplantation, as I mentioned, has no rationale because we can't make myelinating cells, although it has been tried for Pelletier-Merzbacher disease. And transplantation of neuronal and glial precursor cells was successful in an animal model, but in 4 PMD patients, it was tried without significant effects. And there are many open questions regarding this part. There have been some gene therapies which have been performed successfully in mice, and there are preparations going on for a gene dose reduction for Pelletier-Merzbacher disease, but we have to be very careful about the grade of PLP1 suppression. And there have been other treatment approaches in mice and in cell models, and whether that works in patients still remains to be proven. I know of several patients who have been treated with cholesterol ketogenic diet or curcumin, which have been successful in mouse models or cell models, but in patients it was tried without effect. And that still remains challenging. So if we go back to metachromatic leukodystrophy and look at the motor function in patients with motor or cognitive onset, I think you all see that doing a trial in adult patients with a cognitive onset would be very, very difficult to judge regarding efficacy. and very difficult to do because you would need a long time when you look at the clinical outcome. And we don't have good biomarkers to use instead of a clinical outcome. So patients with the slow disorders are particularly challenging for designing clinical treatments. So how to treat hypomyelination? We have many disorders with a lot of different molecular causes. We have patients with very different clinical severities, and we have different disease stages, the early stage and then the later stage when patients deteriorate. So probably we don't need one single approach, but we need more than one approach, and it needs to be tailored to cause and disease stage. So how to evaluate the effects? Of course, and that's something many trials use. We look at motor function because that's a very meaningful endpoint, and you can use established robust scores. You can also score ataxia or dystonia with established scoring systems, and recently many trials think of using wearables, for example, to measure tremor or to measure the time actively up and about. Radiologically, we can look at amount of myelin present. We did that already in 4H with a semi-quantitative method, a scoring system, and there we saw actually that the little myelin present in the brain actually is correlated with motor severity, so that might be a good idea. We can look at axonal integrity and stabilization of atrophy, although this needs a quite long time. Lab markers, we don't have good lab markers for hypomyelination. There is one biomarker called neurofilament light chain, which we looked at in several leukodystrophies. And for example, for metachromatic leukodystrophy in patients with a rapidly progressing disease, it's very, very much elevated. But we checked that in some patients with different hypomyelinating leukodystrophies, and there it is not so much elevated. So we still are looking for good biomarkers. So what have we learned? For H leukodystrophy and POL3 related conditions are several different disorders. In the classic form, we know mildly and severely affected patients. We still need to learn more about glial and neuronal involvement for disease symptoms, and designs for future trials need careful decisions. And we need probably different approaches for different forms and different disease stages. So I would like to thank you for your attention, and the people working at the clinics and in our center on 4H, and also our international collaborators. And
Thank you.
I try to leave some time for questions because I understood we have to finish very much on time.
Yes, thank you so much. Those were excellent presentations. If anyone has any questions, you can type them in the chat or use the raise hand option located under the reactions button at the bottom of the screen. I guess this just means you guys were very thorough.
Tara, is it okay if I just jump in and ask a question then?
Of course.
Thank you. So Dr. Bernard and Dr. Wolf, I know that you know how much these families appreciate hearing from you, but I think it it makes sense to just say it out loud that we just really appreciate your time and dedication to the world of 4-H and the families of 4-H. So thank you. We heard from families that there are sometimes topics that are, difficult to ask. And so we wanted to ask a couple just on behalf of some of the families. And of course, each of you touched a bit. And so Dr. Bernard, you talked about anxiety related to just a myriad of the care involved and stigmas and things of that nature. And we know anxiety is real. Everyone on this call knows that caregiver anxiety is real. And I think that's also demonstrated by ULF graciously hosting a number of support for caregiver talks later today. So, but with that, there were questions about life expectancy and what you can kind of shed. I know it's very difficult because the cases are so individualized and the effects are so individualized. But perhaps Dr. Bernard and of course, Dr. Wolf, two of you have thoughts, but just, there has been some written communication out there about a third or fourth decade. And is that still true for some cases or for some patients? And then how old is the oldest known patient?
So I think the most important thing is that every patient is different. We can't predict, nobody can predict what's going to happen. I think we have, like in the last 10 years, at least, since I've started working on leukodystrophies, we've improved the way we care for patients, and we prevent complications, so we prolong life, and we prolong life with a better quality of life. So I think that's very important to realize. Sorry, my phone just. Yeah. So and then so we do have patients, and I guess Nicole could share her experience as well. The oldest patient that I know about is probably in her 70s, but she's an exception. She's extremely mild, but she's the oldest I know about.
Yeah. And I know several patients in their 50s now, very differently, with very different clinical severity.
We do have a question in the chat. It says, my daughter was just diagnosed with osteoporosis. What treatments are available?
So the treatment for osteoporosis in our center is done by an endocrinologist. So there are different things that can be done. I think there's like calcium, vitamin D, and there's also medication that can be given to slow the progression of the osteoporosis, but I'm not an expert. I don't know, Dr. Wolf, if you have anything else to add.
It depends very much on degree of osteoporosis, on mobility of the patient, and so on. So only to treat only osteoporosis because you have a decreased bone density, I'm not sure whether that's the way to go. Dr. Bernard stressed in her talk that it's really made to measure for every patient this kind of decisions. And the same is true for osteoporosis. And I think that induction of puberty is an important part in preventing osteoporosis, as well as preserving mobility. And also if a child isn't standing or walking anymore, using standing devices, for example, to verticalize patients, because that's good for your bone health, for your spine. But not all patients are treated with a hormone replacement or puberty induction, because this needs also careful decision making. So that's not a solution for all of them, I'm afraid.
Well, we're almost out of time, so if there is any other questions.
I'll ask one question that we also got from a couple of families, and you know, and that I have too. We become really hopeful to see topics like clinical trial prep, you know, coming to 4-H, because it speaks to the great work that you guys are doing and others are doing on like therapy discovery. Could you talk a little bit about, and the question from the family was, how close are we to finding treatments or cures, which is a hard question, but could you spend a moment talking about that if you would?
That's a difficult question. We're never close enough. It's never going to be fast enough. But the big challenge, I guess, with this disorder is it's been very hard to have a representative mouse model. Several groups have tried. So far, the group of Ian Willis has the most has produced the best mouse model, but it still doesn't recapitulate the motor difficulties that we see in patients. So it's still an not optimal mouse model, if you like. So we need this first so that we understand better the disease pathogenesis before we can study more study treatment approach. I think so. I think I don't think, unfortunately, that we're very close. I think we're talking about years, several years before a trial. What do you think, Dr. Wolf?
Yeah, I agree. And I think we have to do our best efforts to have our homework done before starting the trial, meaning describing natural history much better than we used to, because this is really needed later on to decide whether a trial, an intervention is effective or not. And I think no one would like to chase ineffective treatments, because that will slow down the development of a good treatment. So we do need all information we can get.
Thank you.
Okay, well, if there are no further questions, I just wanted to say thank you to our speakers, our sponsors, and of course our audience for making the virtual family conference this year a possibility. We really hope to see you all in person next year. Thank you.
Thank you.
Bye-bye.
Bye.
Bye. Take care.
Bye. Thank you.